Welcome back to the Dr. Doug Show, your resource for bone health, hormone optimization, and healthspan. Well, today we have a really fun interview, and I get a lot of questions around heart health, particularly because we are working with women in the perimenopause, menopause, and even 10, 20 years after menopause. There's so many questions around what to do with cholesterol. Can I take estrogen if I have a history of heart disease? What if I'm over 10 years out from menopause? And so there are so many questions that really lead back to the root of cardiac health, cardiovascular prevention, the prevention of heart disease, et cetera. And I talk about these things a lot, but I met Dr. Michael Twyman, several months ago now. I've seen him at a couple of different conferences, and he is an expert in this space. He's a cardiologist. He is trained in heart attack prevention. He started the group called Apollo Cardiology, and he has really the same perspective that I do on this, but his knowledge is so much deeper because of his cardiology background. So he's been on a bunch of different podcasts like the Dr. Gabrielle Lyon Show, the Mind Body Green podcast. He was in a documentary called Uninflame Me. And Dr. Twyman's done an incredible job of trying to bring forward the current evidence behind what we can do to help prevent heart attack, what the imaging really means. And this is sort of the same thing that we use as we try to risk stratify people when we're looking at estrogen for women that are 10, 20 years out from menopause. What do we do when eating the diet that supports your bone health and supports your medical or your metabolic health also increases your cholesterol? How do we help to unravel these things on an individual basis when there's so much confusion around cholesterol specifically? So this interview with Dr. Twyman is going to get into all those things very specifically. I want to address those three things very clearly in the space of cardiac disease and event prevention for women in this age group. So I hope you enjoy. All right. So Dr. Twyman, so good to have you on the show. As I mentioned in the introduction, this is a massively popular topic. People love to ask questions about cholesterol, heart attack prevention. And the first time I met you and we talked about these things, I realized that you're the guy. I love the way you talk about this. I love the way you look at it. And your entire practice is based on it. So I had to have you on the show. So happy that you're here.
Well, thank you for the opportunity.
Yeah, absolutely. So before we dig into some of the topics, I wanted to let you kind of set the stage. I mentioned in the intro what your practice is, but can you just give a little bit of background around how you got there and how you ended up in this position that you're in now?
Sure. I'm a board certified cardiologist who got very interested in prevention right at the end of my training. I really thought I was going to be a stent jockey, just helping people have, get their arteries open up in the middle of the night when they're having heart attacks. And that's always rewarding. But the thing that always stuck with me was that many of these patients, this wasn't their first rodeo. It wasn't their first heart attack. And they already were taking statins and they're on beta blockers and ACE inhibitors and aspirin, and they keep rolling in. I'm like, there's something that we're missing. And so at some point I stumbled upon functional medicine, and then you start realizing that food has a big role in it, but it's more about the inflammation. So you start learning how to read those type of labs, and then you keep going, and you're like, oh, it's actually about the lining of the arteries, the endothelial health. What do we need to do to protect that? And so then I figured out that that's how I really wanted to address my practice. And 4 years ago, launched, and we really focused on the early detection of vascular disease by focusing on that endothelial lining.
Yeah, and that's beautiful. And I actually want to run through, we probably don't have time to talk about everything you do in your practice, but I want to run through some of the things that I talk about a lot, because most of the time when I talk to patients about them, they've never heard about it. They've never heard about cardiac imaging. Maybe they've heard of a coronary artery calcium score, but they've probably never heard of the next step, which we'll get into. And I think it's so valuable for our patient population, specifically women in the perimenopause, menopause timeframe, women with osteoporosis, because we end up having conversations around lipids and around meat and around saturated fat and around statins and estradiol. And so all these things become really, really important, because this is also a population that has likely early disease. But when they go to their cardiologist, in general, their cardiologist says, I don't care, or I don't really care about your early disease, but don't use estrogen because there's increased risk, or restrict saturated fat because there's increased risk. So they start like knocking out the things that we're talking about are beneficial for their metabolic health, their bone health, their muscle health, et cetera, because of this potential mild risks. So it puts us, you and I are talking the same language, but I want to put this in context. So let's talk a little bit about, let's talk just a little bit about the labs. I think this will go well with what we're going to talk about next. So what are your kind of favorite labs when you do a workup for people that you think people probably don't know about and aren't getting on a regular basis?
Sure. So, I mean, most people, they're used to getting their traditional lipid panel done. They'll probably get a hemoglobin A1C to tell you, are they likely, pre-diabetic? And if they're lucky, they'll get some inflammatory markers. But that's still not enough. So I usually tell people that, if you're just focusing on high blood pressure, if you're diabetic, if you have high cholesterol, you're obese or smoke, that's great. But those are only 5 of 400 risk factors that could actually injure your arteries. So you all have to kind of pair the labs with actually looking at the arteries themselves. And so sticking with the labs, I kind of break it down to 3 big buckets. It's the labs that are going to affect the lining of the artery, the endothelium. These are labs that are going to affect nitric oxide, which is a gas that dilates your arteries. The second bucket is the markers that look at all the oxidative stress and inflammatory markers. So are you rusting from the inside out? Is your arteries, are they on fire? So high sensitivity CRP, oxidized LDL. And then lipids, which I know we'll talk more about, but it's definitely more complicated than good cholesterol, bad cholesterol. And that's the myth. There's no such thing as good cholesterol, bad cholesterol. There's just cholesterol, but you have different lipoproteins or lipid protein carriers that ferry the cholesterol through your arteries. And so if you're going to only look at one lipid number, look at something called apolipoprotein B. It's maybe a $20 test, so it's not that expensive to get done, but it's not part of the standard lipid panel. The ApoB contains all the particles that could potentially stick to your arteries and contribute to plaque formation. So you want to know what that number is.
Yeah, that's beautiful. And we use, we have all of the numbers listed out there on our dashboard, and people, they focus in on that LDL cholesterol, and I try to pull them away and I'm saying, no, look at this ApoB, because it's a better marker of both disease and events, right? Like it is more predictive of events than is LDL cholesterol by itself, because like you just said, it contains all of those, all of the particles that could potentially become a plaque, right? They're atherogenic.
Correct. And sometimes, for the ones that'll watch this in the video, I always show a tennis ball analogy.
Yeah.
Because when you just look at a traditional lipid panel and it says cholesterol, the cholesterol is essentially the passenger inside the lipoprotein. So think of lipoprotein as a tennis ball. It's going to carry your cholesterol, the triglycerides, the vitamins, the phospholipids through your liquid blood, because cholesterol is like oil and vinegar. It's not going to float in your liquid blood. So if you look at an advanced test, you'll see something called LDLP, or particle. That's how many of these tennis balls are floating through your blood vessel at any one time. Apolipoprotein B is essentially this white stripe on this tennis ball. ApoB is a structural protein. It holds this thing together in a sphere. And ApoB also acts as a ligand, or better yet, think of it like a key. So there's different little receptors. The receptors bind to the ApoB and pull it out of circulation.
Yeah, that's great. And so we are following that. I'm glad that wasn't a marker that we're not looking at. Thank you. And we've actually added oxidized LDL back to our panel as well, because we kind of went down this rabbit hole of oxidative stress and how to best measure it. But you can combine both of those worlds and look at ox LDL. So that's another one that's new to our panel.
Yep.
Yeah. The other one that I wanted to bring up, because I've started using it and it's definitely helpful for us, but that's the lipoprotein little a, or LP little a. How does that work into your workup, and what does it mean to you when you see it?
So Lp(a) is the number one genetically inherited lipoprotein that increases your risk of vascular disease by up to double versus somebody who doesn't have it. It's under genetic control. And so it's an LDL subfraction. So it's like an LDL. It has an ApoB on the outside of it, but there's also this extra protein on the outside, apolipoprotein A. And it's that apolipoprotein A that allows it to basically stick to the lining of the arteries a little bit more aggressively. And up to 20% of the population may have high levels of this compound. You only need to check it at least once. And even some of the pediatric guidelines are talking about like checking down into like 8-year-olds, I believe. So if you have it high as a young person, that's somebody you probably want to keep a closer eye on. But this is the kind of the myth that you can look very healthy on the outside, but your arteries can be ravaged with plaque. Now, this was the story of Bob Harper, the guy, The Biggest Loser. Very, very fit on the outside. He has a massive heart attack. He had high levels of lipoprotein A that he did not know about. And so if you have it, it doesn't mean you're necessarily going to have a heart attack, but you have to look at all the other risk factors. Do you have high oxidative stress? Do you have high inflammation? Are you metabolically unwell? You better fix those things, because otherwise you're much more likely to develop plaque in your arteries.
Right. Yeah. And like you mentioned in the beginning, there are so many factors that contribute to atherosclerosis or plaque development. It's not just LDL cholesterol like we're taught, and it's not just the bad cholesterol or saturated fat. And controlling as many of them as possible, but also knowing about the ones that you don't have control over is also really important. And Lp(a) is definitely one of those. So that's great. And that's where we start too. Now we've kind of changed our protocol a little bit, and we're actually getting at least one imaging scan before we even see patients. But let's get into that next step, which is, okay, now we have some biomarkers. We may know something about risk. Well, obviously we know something about age. We've asked about family history. My next step is to start talking about some kind of imaging. I don't have the capacity to do things in an office since I don't have an office. So let's just talk about imaging. And I would love for you to give us your perspective on coronary artery calcium score, or we can call it CAC for short. And then what is the next step for me, which is CCTA. And then we'll get into clearly after that. Just enlighten me on your perspective on these things.
So it's a great question. And it's something that I'm very passionate about talking about, is that, blood work is important and it's a workhorse. I use it every day with every single patient, but that's only one half of the equation. That's what's floating through your blood. I want to know what's actually going on with the arteries, lining of the arteries. And some of those testing, those are the kind of the tests that really look at it way before the person probably even has symptoms. Because unfortunately, most people don't show up to a cardiologist unless they're having symptoms. They're short of breath, they're having chest pain with exercise, their heart's racing, or there's something else that makes them want to go get checked out. But half the time somebody has a heart attack, they had no symptoms before they have the heart attack. So we're trying to find these people way before they have their first symptom. And let's just say that, when should you start this? I mean, atherosclerosis potentially starts in your teens and 20s, but some of these tests, you're probably not going to start until the person's 35, 40 years old. So let's just assume somebody's 40 years old. All these tests would apply in this situation. So the first test you mentioned, the CT coronary calcium scan, essentially think of that like the mammogram for your heart. It has about the same amount of radiation, and it's really just trying to find early stages of disease in your arteries. And so calcium is supposed to be in your bones. You want calcium in the bones. You don't want it in your arteries. So if you have a lot of calcium in your arteries, it means you have plaque in the arteries, and the body is basically forming scars to take care of that plaque. And that plaque calcifies, it ossifies into bone essentially. So the higher your calcium score, the more plaque you have in your arteries. I've seen patients in their 80s still have calcium scores of 0. And I've seen guys who are 36 years old have scores nearly 1,400 and have multivessel disease and end up with stents. So you don't know just by looking at somebody, but the calcium score test really can divide people into low risk or high risk. The one caveat with the calcium score test is it only finds kind of advanced plaque that's already stabilized. It does not see that softer plaque. And you had mentioned some other tests that sort of look at that. So before I send people for the CT angiogram or the Clearly scan, often I will do a carotid intimomedial thickness scan on them in the office. No radiation for that test. And that looks at the arteries on the side of your neck. And it looks at if there's inflammation in the artery lining, which will give you a vascular age. So if you're a 50-year-old woman and your arteries are 70 years old, you're probably not going to like that finding. And you got to figure out what's driving that. Is it Lp(a)? Is it insulin resistance? Is it high homocysteine? You'll figure it out with the blood work. But it will also tell you if you have soft plaque building up there, because it's about 80% correlated. Whatever goes on in your carotid arteries is often going on in your coronary arteries as well.
Yeah, and that's a test that I think I'm probably underutilizing because we'll use a coronary artery calcium score or a CAC, and then frequently we'll take that next step and we'll just go to a CCTA. I don't know, it's just my bias or how I was trained, but I like to hear that too, because it's another step and there's no radiation and it's less expensive.
Correct. And it's not a perfect test. You got to kind of piece it together with what their blood pressure is. And if you have other tests that looks at arterial elasticity, does it all make sense? Because it does have a variability depending on you got to use the exact same software, ideally the same sonographer, because if you did it on a different machine, different day with different people, you'll get a different result. But does that mean the test is invalid? No, it just means it's not that sensitive or specific. So does it rhyme with what everything else that you're looking at?
Yeah. Yeah. And that's kind of the thing that I've been let down with in the past is anything ultrasound is going to have, operator variability. People that will come to me with two very different looking tests done in a very short period of time. And so, it's almost like I look at DEXA in a similar way where there's just so much variability. It's really frustrating to make clinical decisions based off of that. So, all right. So here, yeah, I kind of use CAC the same way. Whereas if somebody comes in and they have a really high score, I probably don't need much more information to do what I'm going to do. Because usually I'm deciding on some kind of a therapy, and often it's estrogen therapy in a woman who is 10, 20 years out or more. And we'll talk about that from menopause. But so if it's grossly positive, really high score, we know they have significant disease, and probably we're just going to not start something like estrogen, and we're going to consult, talk to their cardiologist, talk about potentially adding some kind of therapy. And I want to talk about statins later too. But the next step for me then is usually undertaken if somebody has a score of 0, because that 0 score doesn't tell me as much as my patient hopes it tells me. It doesn't mean that you have no disease. It just means that you have no long-standing disease. It's been there long enough to be calcified. And so then this is where, for me, CCTA comes in. So is that true for you? Is that when you use it?
Very much so, yes. And I mean, I can even just share from personal experience. I've had at least 3 calcium scores that have been 0 in myself. My grandmother on my mom's side died at 64 from a stroke and was having vascular disease in her 40s. So I was just being aggressive. And, I do all the fancy blood work, all the endothelial function testing that I teach my patients, and my numbers generally come out very good. But I ended up doing the clearly CCTA, and I didn't have any hard plaque, but I had the beginning stages of some soft plaque. And obviously I was super frustrated by finding that information out, but hey, what it is, and now I'll take care of it. But the CT angiogram, it gives you 2 big pieces of information that the calcium score test doesn't. So the calcium score, if it's 0, you're generally low risk, but it doesn't tell you about the soft plaque. And that's what the CT angio looks for, because it's the soft plaque that tends to be the plaque that could rupture, and then the blood will clot and you'll have a heart attack. The hard plaque tends not to rupture as much. And so the CT angiogram will tell you, like, this percentage of your plaque is hard, this percentage is soft. And then you can figure out, okay, what do we need to do to get the soft plaque to either become hard or ideally shrink down and go away? And the CT angio will also tell you what most people care about, but honestly, is like they say, reformed invasive cardiologist, I really do not care how much stenosis you have in your arteries. People always want to know, like, well, how much blockage do I have? Well, if you have a 70 to 80% blockage in your arteries, you're likely going to have symptoms when you exercise. You'll probably be short of breath or have chest pain or exercise intolerance. Or if you end up doing a stress test, you'll probably fail the stress test. But it's the people with plaques that are less than 70% that often have the heart attacks. Half the time you have a heart attack, you don't feel that plaque. You have no symptoms of exercising, and so you'll miss it unless you go looking for it. So I care about the stenosis, but I really care about more that do you have a lot of soft plaque.
Right. Yeah. And so then this is where, and I just pulled up my Clearly scan. So for those that are watching this on YouTube, I can share this. And if you're listening to this on a podcast, then, we'll walk you through it. I'm not the master of running through this. So if you want me to look at it a different way, let me know. But I'll share mine. And I think you and I talked about our scores are very similar, which is I have a little bit of plaque as well. My CAC is 0. I'm 45. I'm 46 this month. So then I want to talk about what we do, but let me see. This will be a test for our my tech savviness right here. So let me see if I can get this to pop up on our screen here. So if I do this and I do this, be very careful here. I got too many things open. All right. I think, hey, can you see it?
Yes.
Perfect. All right. And I don't think I'm showing anything I shouldn't show. So that's great. All right. So this is how I generally look at it. And what I love about this scan for me, I just think the 3D representation is so cool.
It's awesome.
Right. Like, it doesn't really actually help me do anything. I just think it's amazing. So for those of you that are seeing this on YouTube, this is a representation of the arteries that feed the heart. So your coronary arteries. I have the main one, the LAD, highlighted here in yellow. And I have a little bit of plaque in this one. So that's the one that we're going to look at. I mean, you can see the other arteries, and you can almost kind of see stenosis here, but what you really want to look at is on the left side of the screen here, and I have it straightened out. You can see what it looks like not straightened out. But this is what's so cool about this software. And then there's so many different ways you can look at this, but the way I generally look at it is with the kind of plaque overlay tool on. And then I'm also adding in, I don't know, one of these other things. But let me just kind of show people, if you're looking at here, if you can see my cursor, there's a yellow circle around the artery. And then I would have you do this, Michael, but you would have to tell me what to do with
Yeah.
You would have to tell me how to drive. And I don't know if I can do that for you. But here's where I have just a little bit of plaque, right? So all of a sudden now we see there's a little beanie on top of my artery. Right.
The little yellow portion is the plaque. So in the middle part of the screen, you're looking like the barrel down of like a garden hose, the lumen where the blood is flowing. So you don't have severe stenosis in that artery. And what I tell patients is that this scan is mostly to look at what's going on the wall of the artery. Plaque is kind of like an iceberg. It's below the surface of the ocean for a long period of time before it pops its head up and starts blocking the lumen where the blood is flowing. So in the picture that he has there, there's this like little yellow section. And so clearly color codes it where yellow is going to be kind of the soft plaque, blue is calcified plaque, and red is the low density plaque or the necrotic plaque. Or I tell patients, that's the plaque that you're really worried about that's more likely to rupture and cause a heart attack. The yellow plaque can be dealt with, but just visualize that, that's a little bit, not a lot in the wall of that artery.
Right. And I can pull up the other part of the study, which actually show, it's like it shows the amount of atheroma, it stages things. But this is an example where I see this often, which is patients will have mild disease. So their cardiologist isn't interested because they don't have significant stenosis, they don't have symptoms, right? Like they're not a candidate for a stent. But when we're talking about what is the likelihood of you having an event if you have high cholesterol or if we start you on estrogen. So then it becomes very interesting. And I think it is a factor. So I use this in that decision making. But what does this mean to you if somebody has, let's just call it mild disease, they have, and I can again pull up the kind of different terms here that they use, but what does that mean to you when somebody has mild disease? What do we do?
It's a great question. And if you're using the Clearly, they do quantify it by stages. They did do a study and they kind of have it like cancer screening. There's stage 0, stage 1, stage 2, stage 3. I've only seen a couple guys who are stage 3. That's very advanced plaque. They're not necessarily symptomatic, but their risk of a heart attack is like 15% over the next couple of years if they don't do something about it. Almost every guy, is stage 1 that I see. And I can just tell you, I've been doing this test for almost 3 years. I've never seen a man over the age of 40 have a perfect score of 0. Never. They have a lot of times where they don't have calcium. Great, you don't expect that. But they almost always have some degree of soft plaque. And I've only seen 2 women have scores of 0. One was in her late 30s. I did her at that stage because her mom died at like 51 from a heart attack. And then I had another lady who was like in her mid 40s. Okay, great. They should not necessarily be on aggressive lipid-lowering therapies unless there's other reasons to be on them at that stage. So you just want to say like, okay, what is the stage of the artery? And then figure out what's floating through the blood and match those things up. Does that make sense?
Right. And so I actually recently had 2 women, and they were in their 60s and had zeros.
Okay.
And I actually sent them back to the company, and I was like, you guys need to run this back because this can't be right. And they said, no, we promise it's true. So it was amazing though. And they were, they were the perfect example that I want to talk about next, which is my patient who has osteoporosis, who didn't start estrogen when they went through menopause for whatever reason. And now let's just say that they're 65, right? So they're 15 years out from menopause. They fall within that, the hard cutoff for a lot of doctors of starting estrogen therapy is 10 years. So now if we're not worried about breast cancer, which is a totally separate conversation, and we're worried about cardiovascular risk, what do I tell this person that has significant osteoporosis, is at risk for fracture? If she has a CCTA with a Clearly of 0, I feel like I'm not worried. Right. You would feel the same way?
I'd feel the same way. I mean, you looked at the arteries and this person is not a higher risk individual.
Right. And this test hasn't been out long enough for me to say there's no way you're going to have a heart attack, but certainly you don't have significant disease where I feel like perhaps you could rupture a plaque. There's no plaque. Right.
And also, I mean, like this, the cardiovascular benefits of estrogen are multitude. But, the main ones is that, it helps with nitric oxide. So nitric oxide is the gas that dilates your arteries. And nitric oxide prevents the lipoproteins from sticking to your arteries in the first place. And it's dependent on estrogen. Estrogen also has an effect on the lipoproteins. So it tends to be when the women go perimenopause, menopause, their lipid profiles change. Their LDL fractions go up, their HDL fractions go down. Part of that's because the LDL receptors are down-regulated. The LDL receptors is kind of like a cargo docking station sitting on the outside of the liver, plucking these particles out of circulation. Without estrogen, there's just not as many of those cargo stations. And so this is the theoretical benefit of that is if a woman starts estrogen when she's perimenopause or shortly into menopause, that you're going to kind of delay their onset of vascular disease. That's why it tends to be that women develop vascular disease 10 years later than men, is because of the cardioprotective effects of estrogen.
Yeah. Yeah, well, that was a great segue. Thank you. That was unplanned. But So, so such a great segue to talk about, this population of women that is, let's call them, well, let's just talk about all women postmenopausal. So I see women generally in kind of like the decade leading up to menopause, and then for really the 2 to 3 decades after. And I always feel the most for women who are in that, kind of 10 to 20, potentially 20 to 30 years out from menopause, because at this point in time, they went through menopause at the same time that the Women's Health Initiative came out. Right. So just bad timing. Everybody got scared about estrogen at the same time. So doctors just stopped talking about it as if it just didn't matter. And unfortunately, that still persists today. But there's a lot of people having this conversation, and I want to continue to contribute to this conversation. So I have this conversation all the time. So what I initially learned, and I think all doctors probably learned this over the last 20 years, what I learned is out of the gate, I learned that estrogen is dangerous. Don't use it. But I'm beyond that now. So now when I look at cardiovascular risk, I was still taught, even in my functional medicine fellowship, I was still taught that estrogen is potentially beneficial for cardiovascular risk up to 10 years after menopause. And then after 10 years from menopause, you shouldn't use it. I disagree with that now, but that's how I practiced initially. But I keep running into that same patient scenario that I just described, which is a woman, let's say she's 12, 15, 18 years out. Is she not a candidate for estrogen, and why? And so I'm writing a book about hormone replacement right now. And so I've been just diving into the research, and it's so fascinating. It's such an amazing field because it's so driven by bias and emotion. So when I really dug into the research, I definitely questioned the data coming out of the Women's Health Initiative because of the way that they ran the study. And for people that have not heard me go on a forever long soapbox talk about this, the short version of this conversation around this topic is that they were very particular in their design about not enrolling women that had symptoms of menopause, because then they would know if they're on placebo, right? Which is smart, actually. But what happens then is that pushes your age group to be older and older. And so they actually had women that were up to 79 years old. The oldest woman in the intervention group was 79 when she started Premarin and Provera, the two hormones that they used in that HRT group. And so what they found is that in general, there was a higher risk of heart attack. So when they looked at the data, they looked at the age, they said, wow, well, this group is over 10 years out from menopause, so therefore the risk is higher. There's a 2018 study that I read, and I think there's other studies that have looked at this too, but when you look at a subgroup analysis of those women, you can see that early on, estrogen therapy, even in the form of Premarin, which I don't like, but estrogen therapy is protective of breast cancer. At 10 to 20 years out, it's neutral of breast cancer. At 20 to 30, it increases just slightly. And so then we start to have this really challenging conversation. So in your practice, when you're looking at women who are in this age group, because I'm sure you see them too, how do you wrap your mind around that? What do you tell women around the risk, plus or minus estrogen? Because I know you're not prescribing it, but how do you wrap your mind around that risk?
I think it's just having that conversation with the person who's sitting in front of you, letting them understand that like vascular disease is still the biggest risk that they likely face. 1 in 3 women, that's how they're going to die. Breast cancer, while scary, is like tenfold less risky for them to die. So are you concerned about that this person has a very strong history of vascular disease? Probably accept whatever risk you're going to get with the estrogen therapy, from a breast cancer standpoint, even if it's that small, because you might be reducing the cardiovascular side of the equation. But I haven't seen clinically that many problems with women as long as they're kept in physiological ranges through whatever preparation that the person is prescribing to them. It's the problems when they get really hyperestrogenic, where they get into the thrombo, embolism type issues and everything else that you don't want. So I think it's really the people who benefited the most tend to be the perimenopause people and the people who are just early into it, who are symptomatic with the vasomotor symptoms. And my understanding is that the vasomotor symptoms are often because they have microcirculation issues. They have nitric oxide issues. And that's probably why that's happening. So you give them estrogen, the nitric oxide level gets better, and a lot of those vasomotor symptoms go away. So that's how it kind of probably falls back into the world that I look at, is that the women who respond well, great, that's probably more protective to their arteries. So it's nuance, and it's always got to be the person who's in front of you, like, what are they most concerned about? But in my kind of history of doing this, I've not seen it be a big problem for the majority of women.
Yeah. Yeah, and I love the way that you said that. And I think of the way that I run our practice, and there are a lot of providers that use hormone therapy that don't like to test blood levels because the statement, and this drives me bonkers, but the statement is that, well, the drug companies have already done all that testing, so I don't need to test. But I see really wide ranges of estrogen levels with different types of therapy. And often it's too low, but sometimes it is that it's too high. I get women coming in with estrogens in the 400, 500, and I'm like, woo, like you don't need to have a cycle in your postmenopausal state. Like, let's get this back under control. So I'm a big advocate for testing, understanding what serum estradiol levels are, and then adjusting therapy based off of that. So I'm glad you mentioned it like that. I don't want to get into the forms of estrogen because that's sort of beyond this conversation. So then let's take a little pivot here and talk about the other thing that happens. And you kind of mentioned this a little bit, but so often I hear my patients will come in, they'll look at their cholesterol and they sort of just like have this look on their face like, ugh, I'm defeated because my cholesterol keeps going up no matter what I do. Right. And cholesterol is such a funny topic, but you mentioned earlier that estrogen will have an impact on lipid levels and a inversely related relationship, right? So more estrogen you have, generally your LDL and other cholesterol is going to go down. HDL goes up, which is protective in general. So walk me through kind of how you would look at lipids for a woman who is, let's say she's 10 years out from menopause. Total and LDL and ApoB are up. LP(a) is whatever you want to call it. But what's your conversation with a woman around cholesterol there?
So, I mean, it's very similar to what you would have with guys. It's, what is the health of the lining of the arteries, the endothelium? Can the arteries make nitric oxide? If your arteries can make nitric oxide, you don't tend to go down the pathway where you get vascular inflammation and plaque forming. So think of nitric oxide as protective. It's like a force field preventing the cholesterol particles from sticking to the arteries in the first place. So we would do testing that would look at nitric oxide levels. And we would do the test that would look at carotid scans or calcium scans or clearly. Like, is this person high risk of having events or not? If the answer is yes, then you're more likely to use pharmaceutical interventions to try to lower that risk. But after you know what the health of the arteries are, you look at the biomarkers. And so mostly look at ApoB because all things considered, the more ApoB particles that you have, the more risk that some of them are going to get retained in the lining of the arteries and plaque could build up. But there's nearly 3,000 genes that affect lipid metabolism. And so I've had many of those patients too that they think they're defeated, that their lipids are high. But you have to think about it as like theologically, like cholesterol is not bad for you. You have to have cholesterol or you're not alive. You need it for your immune system. You need it for your bile to digest fats. You need it for your cell membranes. You need it for your hormones. But at a certain stage, we weren't designed to live 80, 90 years. We're supposed to live like 40, 50 years and then die off. We didn't live long enough to develop significant vascular disease for the most part. So at some point, if you're 45, 50, 55 years old and your lipids are high and you're starting to show signs of plaque in your arteries, if you want to make it to 80, you're probably going to have to do something about this. And so figure out using testing, okay, is it more an issue that the liver is hyperproducing a lot of the sterols? Okay, well, then that's where statins, bempedoic acid, red yeast rice, bergamot may work better. Or is it a problem more with the gut? Is this person's gut reabsorbing a lot of the cholesterol? Because that's really the only way cholesterol gets out of your body is through the gut. 1 in 5 people hyperabsorb their cholesterol. And so it's kind of like sends the cholesterol back and it circulates around the system again. And so that's where ezetimibe would work better by blocking those gates. So you can really personalize it based off the lab testing and say like, this nutrient, this supplement, this medication is likely to work for this patient who's sitting in front.
Yeah. Yeah. I love that you mentioned that too. And I'm actually one of those hyper absorbers. So Zetia for me massively drops my cholesterol, like remarkably. It's incredible. So let's talk a little bit about the nitric oxide side of this. What biomarkers are you using to look at nitric oxide, if any?
So on the biomarkers, it's mostly going to be urine microalbumin creatinine. That's a good starting point. Most doctors are familiar with this. You check it when people are diabetic or hypertensive. But the way to think about it from nitric oxide is that if you have proteinuria and you're leaking protein in your urine, that means that the lining to the arteries to the kidneys is leaky and the protein is getting through it. So the higher your microalbumin creatinine, all things being considered, it's often a marker that the person has low nitric oxide. There's other things you can directly measure: asymmetric dimethylarginine, symmetric dimethylarginine. If those are high, Those competitively inhibit certain enzymes that affect nitric oxide. Homocysteine. So some patients have methylation issues that cause their homocysteine levels to be high. When that amino acid's high, that tends to drive down nitric oxide. And then the other one that often we'll check is uric acid. So most people know about this one. If it's high, it's more likely to cause gout, which is a painful crystal arthritis. But high uric acid directly oxidizes and damages the lining to the arteries, the glycocalyx, and then that causes an effect on making less nitric oxide because there's less transduction of blood across the glycocalyx. So those are the 3 or 4 big tests that I would look at that are biomarkers. But then there's some ways that you can look at, like there's salivary nitric oxide testing strips you can get. They're kind of like litmus paper, you put saliva on it. The brighter the red it is, the more that your oral pathway is able to make nitric oxide through the foods that you eat. And that's mostly going to be nitrate-rich foods like beets, spinach, arugula, high nitrate foods. If you have the right bacteria in your saliva, can ultimately convert into nitric oxide in your stomach. And then there are various kind of like, I call them toys, but the toys I have in my office that look at arterial elasticity. You can actually measure, the hyperemia response when you put a stressor to the arteries. It's kind of like a stress test, in the stress lab. Well, we're doing stress tests to the arteries to see, can they make nitric oxide?
Yeah. Yeah, that's awesome. I wish I could just send an endopath to people's homes and have them do that by themselves. Because I think it's a really cool test. Yeah, that's really helpful. And those are some biomarkers that have been on my lab in the past that have sort of fallen off because it's just not kind of our primary focus. But yeah, those are really all good thoughts there. And then from a treatment perspective, you mentioned, I like your list of LDL specific nutraceuticals. Bergamot's the one that we tend to use the most. What about nitric oxide though? I know you and I have talked about some stuff in the past. What's your, if you were to give somebody a list of nutraceutical recommendations or potentially pharmaceutical recommendations, what would you recommend for people there?
For the nitric oxide side, tend to think about it as like your arteries have a lining called the endothelium. It's one cell thick. It's the protective coating to the lining of the arteries. If you took out all your endothelium, it'd be about the surface area of 6 tennis courts. So it's actually your largest organ, and you definitely probably don't know about it. But sitting on top of the endothelium is something called the glycocalyx, and it's a protective gel coat. The best way to think about it is like if you took a fish out of water and it's slimy, that slime is essentially the glycocalyx, and that's protecting the endothelium. There's lots of things that damage that glycocalyx. Smoking, infections, glucose, insulin, heavy metals, many, many things. There are nitric oxide promoters that are lozenges and capsules. Dr. Nathan Bryan, created Neo 40. It's got N101. Those are very good lozenges. There's another company, Calroy, that makes a product called Vasconox that also tends to help with the nitric oxide production. And then there's glycocalyx promoters. So if that gel coat is damaged, you can give things that kind of regrow it. So think of like a seabed, like the grass got cut. You're just trying to regrow that grass with these promoters.
Yeah, Vasconox is the one that we've really kind of gone toward just because of the longer half-life of the product and it's easier to dose than Neo 40. Although I do like sucking on that lozenge. Yeah, it's working.
It's like candy.
Yeah. Yeah. What are your thoughts on using like a drug like tadalafil specifically to block nitric oxide breakdown? For things other than erectile dysfunction?
That's a great question because I get that one a lot. I have it actually on my intake form for guys just asking like, do they use these products? It's not that, I'm judging them in any way that they have to use them, but ask them like, why? If it's just for like, I have some patients who use it just because they're like, I like caffeine because that keeps my brain awake, but I just like this because this works better. I'm like, okay, you're just using it for performance enhancing. You don't need it to have an erection. Okay, got it. But it's one of those things where it's like, these medicines don't provide nitric oxide. They just help keep nitric oxide around longer, prevents the cyclic GMP from breaking down. So the way to think about it is like you got to fill the nitric oxide funnel up with nitrate-rich foods or sunlight striking your skin or exercise or one of these nitric oxide promoting supplements. Put nitric oxide into the funnel, and then the tadalafil and the Viagra medicines, they just prevent it from breaking down. So it just acts longer. So for some guys, I think it's very useful. They got like BPH symptoms. Sometimes it's helpful. But I've not yet seen the data that, just for general cardiovascular protection, I've not seen the data that's really ready for prime time yet because there are side effects for these medicines for some guys.
Yeah. Yeah. It's one of these things that I've gone back and forth on, like, should I have all of my patients on, a 5 milligram daily Cialis? because there are doctors out there that are doing that, and I get it. It makes sense. And if the only side effect is better erectile function, I don't think there's probably too many guys that are going to turn that one down. What about tadalafil for women? Any concerns there that you see? Because I can't come up with any.
No, not really. But I mean, it's the same as for guys. It's like, because it's going to keep nitric oxide around for longer. Is it causing an unsafe drop in blood pressure? Is it causing visual changes because it's dilating blood vessels to your eyes? Is it causing headaches? Sometimes that's the reason, people can't tolerate these long-acting nitrates. It's just that the vasodilation in the brain, they don't like that sensation. So as long as it's not causing, side effects that they're noticing, no real concerns with the low dose for women.
Yeah, I can't think that I have any women that I've actually prescribed it for, but I know it's been close a lot of times, but I just haven't really made that leap to start prescribing it for women. I have heard some physicians in the sexual health space, because we talk a lot about testosterone for women, and we get into that space quite a bit. And there are a number of providers that are talking about using, the 5 milligram tadalafil for, sexual enhancement for women as well, which does make sense. Again, I haven't gone there yet. So then, all right, let's talk about this last topic that I have listed here, which is we kind of talked about what we would do with kind of the workup for women that have higher cholesterol, even if let's say they start on hormone replacement, but it's still elevated, they've got some risk, and their primary care doctors told them to start a statin drug. Now, I was trained that if you look at the data on statins from going back decades, that statins work better for primary prevention, meaning stopping that first heart attack, for men than for women. I've also heard providers go so far as to say that no woman should be on a statin ever. And then you hear other people that say that all humans should be on statins regardless of gender, height, whatever. So help me make sense of this. I have my own protocol, but I'd love to hear yours and how you deal with women specifically when they have elevated cholesterol and some kind of risk.
It's a great question, and one I face every day. And it's what I tell people is that statins are tools. I do not think they should be in the water and everybody should be taking them. And the converse is I don't think they're poison where nobody should be taking them. The people who benefit the most are the people who are at higher risk. They're the people who have already had their events. They've had heart attacks. They got stents. They got bypass. You're just trying to prevent their second one. There's really no controversy in those type of people. The people where the controversy is the primary prevention. They've never had an event. But the challenge gets to be that if you start doing these more novel testing, like the Clearly scan and calcium scan, there's studies on these, but not nearly as much. So when you look at somebody who's, quote, primary prevention, well, if they've not had one of these tests, are they truly primary, or are they like between primary and secondary? Because if you do it clearly and they've not had an event, it's they're pretty close to, they're not really low risk. And so I always will look at the arteries, and that kind of helps me really judge, okay, this person's low risk, lifestyle, supplements for a while, or they're high risk. And then you have the conversation with them. But statins, they get a bad rap, but if you use them in the right way, most people can tolerate them. The main risk of most statins is the muscle symptoms. We'll get muscle pains, weakness. I've never seen a case of rhabdomyolysis from statins. I was a military doctor for a while. I saw tons and tons of cases of rhabdomyolysis when the DIs would, PT the recruits too hard. I've never seen it from a statin. Now, that being said, I don't tend to use the high dose statins anymore. I tend to use much lower dose, like 5 or 10 milligrams of rosuvastatin, or use pravastatin for people who are more sensitive. And then if you really do a lot of these advanced testing that we've been talking about, well, if you look at their vitamin D levels, if they're deficient, they're more likely to have side effects, particularly muscle symptoms. If they're low CoQ10, more likely to have muscle symptoms. If they're hypothyroid, more likely to have muscle symptoms. And then the more genetic way to look at it is ApoE. If they're an ApoE4 carrier,
Yep.
They have a little bit higher risk of Alzheimer's and diabetes, but they also tend not to respond as well to the high dose statins. They tend to have more issues with their glucose and muscles. And then there's another one that's, you got to kind of check a special lab to look at, but it's called SLCO1B1. That gene, if you have abnormal copies, 3 to 4 times increased risk to have muscle symptoms with statins. So those people I tend not to challenge, initially use ezetimibe, use PCSK9 inhibitors, use something else, unless there's no other options for those people. So you can find the right tool for the job often, but it's one of those cases where, like on a podcast, it's very hard. Good cholesterol, bad cholesterol. Cholesterol's real high, here's statin. That's too simplistic. It's it takes 5 minutes to explain what an ApoB particle is, and then you do these tests and be like, see, you would respond to this medication.
Yeah. Yeah. And that's sort of where I look at the idea that if you have worsening disease, I'm not so interested in your gender. I'm more interested in what's happening in the artery level. if it's getting worse and you look like you would benefit from a statin, I think it makes sense. Even if it is the 1.5 prevention, right? It's like primary 0.5. Yeah, so that's the approach that I take as well. It is always hard because there's such emotions around statins. It's not quite as emotional as estrogen. I wanted to ask too, the benefit of a low dose, you mentioned like a 5 milligram or 10 milligram rosuvastatin or Crestor. Catch me up on the data on using a low dose like 5 or 10 milligrams versus a higher dose to get, ApoB or LDL-C to, quote unquote target. Is it as effective? Not quite as effective? What's your take on the literature there?
It typically is, in my experience, you generally get about 80% of the benefit at the lowest doses. So if somebody's very hesitant to say, okay, can we try the lowest dose? And if they're really hesitant, like, can we try the lowest dose 2 days a week? Because you still get a benefit because it has a 3-day half-life. So give it 2 days a week. And if you tolerate it, didn't have any muscle symptoms, retest their blood work, 6-8 weeks later, and be like, see, your numbers got much better and you didn't have any side effects. Can we stay on this dose or bump it up to 5 milligrams daily? So just start them slow and titrate up. And then if you're using the Boston Heart Lab panel, you can use what's known as the cholesterol balance test. And you can look at if they're a hyperproducer of sterols. So if they have very high levels of desmosterol or lamphosterol, then you have a little bit more room to keep dialing up the statin dose. So the analogy I use for patients is think of like a bathtub filling up with water. There's 3 main ways you can prevent the water from overflowing. You can reach in there and turn off the faucet. That's essentially like using a statin or bempedoic acid or red yeast rice or bergamot. Make less cholesterol in the liver so less water goes in the bathtub. The other issue is their drain plug blocked? Well, this is where the supplement berberine can open it up a little bit, or this is where Repatha, Praluent, Ilasclerin, the PCSK9 inhibitors, they open up the drain. Basically, the LDL receptor stays out longer, plucks out these particles faster, delivers them to the gut. And then the issue is once the water is in the main sewer pipe, does it leave or is there a blockage in there? Well, that's where ezetimibe would work, is make sure that the water leaves to the street. So if you use this test, you can figure out which person is going to respond best to which agent.
Yeah, that's awesome. And we have used it in the past. It's not part of our current panel. We sort of work our way around it. We use genetics too. On our genetic panel, you can predict hyperabsorbers to some extent, and I've seen that be pretty consistent. So, all right, we've hit my threshold. I try to keep these under 45 minutes, and we're right at 45 minutes. I have so many questions I could ask you, Michael, but I think let's cut it short here. If I need to bring you back, we'll schedule that out in the future as well. But these topics are so needed for this audience, for women that have osteoporosis, going through menopause, so much confusion. So thank you so much for your time. Give us a quick, where can people reach you? How can they learn more about you? That kind of stuff.
Well, thank you again for the opportunity to speak to your audience. I just want to let people know that, their vascular health is in their hands. I mean, your doctor is your Sherpa essentially, but there's so many things that you can do to mitigate your risk of having a heart attack or stroke. And just if you have more interest in the things that I talked about today, I'm on social media, mostly on Instagram, just at Dr. Twyman. Every Monday, 6 p.m. Central Time, I do a Ask Me Anything. So people have questions that they didn't, remember what I said here, just log on there and ask me there. And then also my website is just drtwyman.com. There's other links to my other podcasts there as well.
Yeah, awesome. Well, thanks again. And my guess is we'll probably end up doing this again, but I really appreciate your time.
Sure. Thank you.
All right. Well, I hope you enjoyed that interview and it helped to answer some of your questions around what to do under these very specific and unique circumstances. So as usual, if you're looking for help around osteoporosis and creating a comprehensive program, please consider joining our masterclass or heading over to optimalbonehealth.com and looking at some of our other resources like our Bone Foundations course and of course our full service program. So check out those resources as needed. If you haven't already, please subscribe to this channel to help us help others, and I'll see you in the next video. Thanks so much for your attention.